So next slide. So the workforce of people who can make a difference. We've got sort of specialists in palliative care and generalists. We use those terms. I think you do as well, do you, to some degree? Generalists meaning people who don't just care for dying patients. And then the lay people. Simon, is that the same kind of terminology you use?
Yes, we're a little bit confused. Some people are a bit insulted. Non-specialist is also used, but generalist is the general term. Yeah.
Non-specialist is one of those difficult terms because you might be a cardiologist, but non-specialist in palliative care, mightn't you? So, yes, I know, and it's hard to define them. We had this was all defined in one of our policy documents, but still there's some difficulties. But within our specialty of palliative care in the UK, which obviously has emphasised palliative care and hospice for many years, we've got 5,500 workforce. If you're just pressing the button. And then the generalists, we've got actually 2.5 million, so about 1.2, 1.3 in health and social care. And these are the people in primary care, in care homes, domiciliary care, hospital. A lot of care assistants, a lot of low-wage people who make a difference, as well as, of course, generalist doctors. And these are the frontline staff that most dying patients, or most people in the final year of life will be under the care of. And then, of course, you've got the general public, the public awareness, community care, community support, and a whole lot of work that can be done and is being done, mobilising public awareness. And I'm sure in communities like yours, really developing some kind of community care, and that's a really valuable part of the jigsaw. So the bit that we focus on within Girls Standards Framework GSF is focusing on enabling generalists to better work with specialists and others so that we can all really play our part. And it isn't a territorial thing. It's about bringing generalists up to speed and being able to deliver the best kind of care that they can with all the limitations that they have, and so to enable people to have the best kind of care provided by the whole team. So the next slide, that's just by way of introduction of the context. So GSF Centre, we started over 12 years ago, just within primary care, but now we've established this as a centre within end-of-life care, mainly training and enablement, and I'll go through some of that. But and it's focusing on generalist frontline staff, and it's mainstreamed within policy. As I said there, every organisation involved in providing end-of-life care will be expected to adopt a coordination process such as the GSF. That was in the strategy, but that was just one of the quotes. So it's very much about coordination and the sort of framework that then is adapted by each organisation. So next slide. Oh yes, I did a bit about the background. So we started in really 98, and if you just flick through this, Joe. So it really developed from primary care. So I've been a GP 23 years and worked in hospices for 16 years, some of those, and did lots of training and nearly became a palliative care consultant and did an MSc and diploma and lots of different things, and then wanted to come back to primary care to work with GPs and district nurses to try and enable the best care that we can. So this has been very much clinicians and patients and carers gathering around the table and seeing how we can do. And it grew slowly, but now within primary care, we had a sort of phased programme, and the underlying feeling was that palliative care really matters to GPs, district nurses and others. And they're not happy that care isn't so good. And then it developed into care homes, ACS, hospitals, and domiciliary care and other areas. But it very much grew from grassroots, from a sense of dissatisfaction that it wasn't quite good enough. So I just skip through the next few slides. So that was national policy for GSF. It's in every kind of policy, mainstream policy document that we needed to, including the Labour and Tory manifestos and white papers and strategy and then specific guidance, because being adopted, especially by primary care, it became a framework that was adaptable for lots of different areas. So the next one, GSF is quite hard to pinpoint what it is, but it's a sort of toolkit and structure and framework of ideas and concepts and tools that help, particularly enabling generalists, improving confidence of staff. That's a very big thing, especially in care homes. We find it's about releasing people with natural talents and tapping into the reasons they came into healthcare and social care in the first place. That's a really big part of what we do, trying to improve confidence. We certainly find that in care homes work and domiciliary care. It's about system change, so it's about the way people interact together. It's not about one person, it's about how people move around the system together. And it's very much focusing on earlier pre-planning care, proactive care. So identifying people early enough and then putting a plan in place to enable their wishes to be lived out and acted upon. And it's not particularly focused on only one group, regardless of diagnosis, but the non-cancer frail elderly we particularly look at because of the burgeoning needs. And decreasing hospitalisation and increasing cross-boundary care are two other big focuses of what we look at. So the next slide about the sort of orchestra, in some ways it's a bit like the conductor of an orchestra. When you look at all the different people involved, different services, different areas, in some ways you need something that coordinates it all. Otherwise you get the first fiddle going off in one way and the piccolo somewhere else, and not very harmonious. There's a nice GP who, when I was giving a talk a couple of weeks ago, he said, you're pushing at an open door, we know about this, we're all singing from the same song sheet, we're just not yet singing in the choir. So he talked about the choir rather than the orchestra. So it's about coordination so that people don't get too much input, but they get the right kind of care at the right time, which might sound so simple, but actually delivering it is really hard. So next one, if you just flick through these, Joe, I just wanted to make the point really that GSF focuses on the organisation, and not the individual bit of head knowledge, but the organisation, the way the team interacts, because it's about, so therefore when we teach in teams, and we ask people to interact a lot together and go away and do things and then come back. So it's more about what you do than what you know. We don't test what people know, we test what people have done, have changed. And then, of course, it links up with the wider area, the wider community, how that will link up, say, a primary care team with hospices and community and others, and then linked up with national regulation. So there's a lot of work on this, it's called microsystem work, about that key team at the coalface, and that's the group that we mainly work in. So it means that e-learning, we don't do traditional e-learning one-to-one, although we do some of that, but we do mainly working in teams and interaction, people trying things out and developing it. So that's organisational change. All right, so the next one, what does the GSF aim to do? Three main things: quality of care, improve the quality of care, improve collaboration and coordination and cross-boundary communication, and decrease hospitalisation, so decrease inappropriate hospital admissions and length of stay. So those three themes keep coming up in our things that we do. And then next one. The three ways that we deliver this are running training programs and have a toolkit of resources which are adaptable for each training program, and we've got 4 active ones at the moment, another one starting in the autumn. And then different measures and metrics, so we can put different things together to try and assess, but they're measurement for improvement, not measuring for judgment, although it's very helpful to know cumulative response, so I'll come back to that. So one way of looking at it, we use the head, hands, heart images, lots of different images, but head, hands, heart is quite a good one. So the head is the clinical knowledge, what to do, but the hands, the organisation, that was what was always falling down, we found. GPs, when I started doing this work, really wanted to give good care, but it was just that they didn't have the right drug at 3 in the morning. They might have known exactly the right dose to give, but they just didn't have the right drug at the right time with the right person. And so it's about the organisation and the system and the how, which is usually the thing that can fall down when... So it isn't just about training head knowledge and people knowing things, it's actually about sort of training and enablement, organisational hand knowledge. So that the heart, the sort of compassionate care, spiritual care, experience of care, the human dimension really comes, right? And this is rooted in the Institute of Healthcare Improvement work, Don Bowick. He talks about evidence-based, systems-minded, patient-centred, same kind of thing. But we use that image, head, hand, heart, in some of the other work, like domiciliary care, because it's a bit simple, it's a bit easier to grasp. So next one, I've just got the 4 main training programs. The primary care one started from 2000, and now 90-95% of practices have a palliative care register and hold a meeting. Any of the GPs there at the moment might know a bit about GSF and might know that this is working to some extent in the UK. It is not perfect at all. It isn't perfect, but at least we can say that 90-95% of practices have a register and have a meeting potentially. Now we've got to work hard at building on that, but that structure is there, and that's sort of what we call stage 1, getting... Joe, we talked a bit earlier about registers, whether that was the same kind of language that you use. In the primary care team, it's quite common to have a register of diabetics and asthmatics and things. Is that, Simon, is that sort of common as well?
Not at this point, no.
But I suppose if you're talking about a whole population of patients under the care of, say, a GP, you first got to pick up the particular group of patients, and then. So I'll just whiz through the others because I'll mention them later. The care homes, over 2,000 care homes trained and about 200 a year accredited. The hospitals, we've piloted in 15 hospitals, and now another 10 it is now actually in phase 2. And the hospital is a very key part of the work. We're finding where the hospitals join in, it really makes a difference in the whole cross-boundary care. And then we're doing a bit of work on domiciliary care. Domiciliary care are the people who go into people's homes, the so-called unskilled and non-nursing clinical assistants, carers, spending half an hour getting people dressed or whatever. So they play a very important role as well. So just next slide about primary care. So in some ways it's easier to break it down to stage 1, stage 2. Stage 1 is bringing everyone up to the level of, or most people, up to the level of having a register of palliative care patients, or however you like to phrase it. This got mainstreamed through the way GPs are paid. It's called QOF, Quality Outcome Framework, and they stipulated that if you suspect people are in the final year or so of life, that they're put on this register. In effect, it's largely 6 months or so. But we know that 3 to 6 months before death is a really crucial time for repeated admissions. And so even if it isn't quite right, at least, well, we know it's not quite right, but at least there's the potential structure of a register that most practices have. And from that they have a multidisciplinary team meeting. The QOF stipulates 3 monthly. We used to say monthly to try and plan for the care of these patients. I'll come back to stage 2 when we did when I was just saying about the next stage. So next slide. So in 2009-10 we did this National Primary Care Snapshot audit to look at how deeply embedded this work was. We knew before that 60% of GP practices said they were doing GSF, but they were probably just doing the foundation level. So this was the biggest survey that had been done. 502 GP practices, 4,500 patients. And the key findings, it was supported by the Department of Health, the key findings were that of all the deaths, so they looked at every death from February and March in 2009, no matter whatever their diagnosis or wherever they died or whether they were on the register or not. But they did find that only a quarter of patients who died were on the register, which in some ways is good news because it meant in this sample they were picking up a quarter of all patient deaths were being identified and put on the register, but 3/4 weren't. So that was quite salutary, really. The second important thing was of the patients that were on the register, only a quarter had non-cancer, so we're still fairly cancer-dominated. So it still meant, and I still find this now, that there are some practices where they've just got a few cancer patients on the register. So it's our task to try and move them on to thinking about the non-cancer patients and to extending this to more patients. But the third really important finding was that all the patients on the register received better coordinated care when we compared lots of factors, even advanced care planning, anticipatory prescribing, handover form, carer support, even access to benefits, access to specialised care, all the kind of criteria for good quality care. If they had been identified and put on this palliative care register, they were much more likely to have received good, well-coordinated care and much more likely to die where they chose. So it sort of validated the whole factor that we need to improve our earlier identification of patients in order to give them better coordinated care. So the next slide shows, 42% of all these deaths, the GPs at the time estimated were sudden deaths. And I should think most of us think like that. It meant that only a quarter of patients were actually on the register. So for us, it tasked us with trying to shift that figure from maybe half to maybe a quarter, maybe up to a half or wherever. But still, 3 out of 4 people who die weren't identified and put on a register. Not that we're ever going to get to 100%, we know that, but just shifting that figure upwards. So we do a lot of work with practices now. We do lots of workshops and conferences and challenges, and I'm writing soon with this patient charter to every GP practice in the UK with the RCGP saying, what is your figure, what is the proportion of people who die who are on the register, and what proportion of them have cancer and non-cancer. So just to try and challenge GPs.